We are going to start the Kanski lecture series Conjunctiva part 7, and in this part we are going to study about the degenerations. So basically degenerations are the corneal diseases that are basically related to the age related changes that occur in the conjunctiva. It can be some environmental factors that causes the precipitation of these conditions. So let's get started. First of all, we will discuss about the pinguicuela. The pinguicuela introduction. A pinguicuela, plural pinguiculae, is an innocuous but extremely common asymptomatic elastotic degeneration of the conjunctival stroma. So conjunctival stroma become degenerated in this case, and basically it is a nodule that is formed in the across the horizontal palpebral region near to the limbus. A yellow white mound or aggregation of the smaller mounds is seen on the bulbar conjunctiva adjacent to the limbus. So basically it is seen as a mound on the adjacent to limbus. It is more frequently located at the nasal than the temporal limbus, but it is frequently present at both. So basically, the pinguicuela, and next we are going to study about the pterygium. Both occurs in the more frequently on the nasal side of the eye, and temporally it is very rare, but it can occur at the temporal side as well. Calcification is occasionally present. The cause is believed to be actinic damage, similar to the etiology of the pterygium. So, actinic damage is basically when there is a UV radiation that damages the conjunctiva, which pinguicuela resembles histologically. The distinction is that the limbal barrier to extension has remained intact with the pinguicuela, thought transformation can occur. Occasionally, a pinguicuela may become acutely inflamed pinguiculitis, particularly if the lesion is prominent or overlying calcification leads to the epithelial breakdown. So basically, the pinguicuela is a nodule that is around the limbus, but it does not crosses onto the cornea. It does not proceed onto the cornea like a pterygium. So it is one of the distinction between the pinguicuela and the pterygium, and it also has calcifications in it. So what are the treatment is usually unnecessary because the growth is absent or very slow. Irritation may be treated with topical lubrication. So dry eye is also a factor of causing these types of conditions, so one have to lubricate the eye. Pinguiculitis, which is the inflammation of the pinguicuela, can be treated with lubrication if mild and with a short course of topical steroid. Excision may be indicated for cosmetic reason or for the significant irritation. In contrast to pterygium, the recurrence rate is low and the simple excision is usually adequate. Thermal laser ablation can be effective. Gentian violet marking may be necessary to ensure adequate absorption in lighter skinned individuals. So basically you do not have to treat the pinguicuela. You will all just give the patient a lubricant, or you can give a mild steroid in case of an inflammation. Excision is only done for the cosmetic purpose. When a patient is concerned for his cosmesis, then you can do the excision, and for the excision it can be the simple excision or it can be the thermal laser ablation. And for when we are doing thermal laser ablation, because it is a kind of a laser, so we mark it with the gentian violet. So next is a pterygium. Pterygium is introduction. A pterygium, plural pterygia, is a triangular fibrovascular subepithelial ingrowth of a degenerative bulbar conjunctival tissue over the limbus onto the cornea. So basically it is a fibrovascular subepithelial ingrowth. So basically the conjunctiva is degenerative, and in the subepithelial region there is a fibrovascular growth, and it extends into the cornea. It typically develops in patients who have been living in a sunny countries, and as with pinguicuela may be represent a response to ultraviolet exposure and to other factors such as chronic surface dryness. So in a case where there is a lot of UV radiation, these conditions are more prevalent, and also when there is a lot of dryness. The condition tends to run in families. A trichum is histologically similar to a pinguicula and shows elastotic degeneration, changes in vascularized subepithelial stromal collagen. So stromal collagen will be devascularized and there will be the degenerative changes. In contrast to pinguicula, trachea encroaches onto the cornea, invading the Bowman's layer. So it is very important which layer of the cornea the trachea invades. So Bowman's layer. So whenever you are excising the trachea, you should remove it and you should be uh, extend up to the Bowman's layer, excise up to the Bowman's layer. So pseudotrichum appears similar clinically but is caused by a band of conjunctiva adherent to an area of compromised cornea as its apex. It forms as a response to an acute inflammatory episode such as chemical burn, corneal ulcers, especially marginal trauma and cicatrician conjunctivitis. So there is another condition known as pseudotrigium, which is not a true trigium but it looks like a trigium. And how will you identify it? Because in the cornea there is certain kind of damage and the conjunctiva, the fold band of conjunctiva encroaches onto the cornea in that side, that is called the pseudotrigia, and it occurs in the chemical burn, corneal ulcer and trauma and cicatrician conjunctivitis. So first let's see figure. So this is a pinguicula. A is showing pinguicula, so you can see this is a mold that is adjacent to the limbus. C is showing the calcification that is occurring in the case of a pinguicula, and C is showing the pinguicularitis, which is the inflammation of the pinguicula. So, and this is a trigium. Histology showing the collagenous degenerative changes in vascular subepithelial stroma. B is showing the trigium, showing cap, body, cap, head, body, and a Stalker's line. So Stalker's line is an arrow. So basically this is a Stalker line, which is basically the iron deposition in the iron deposition in the epithelium or before the head of the cornea, trigium. So we know that trigium has some parts, we will discuss it later. C is showing the inflamed trigium and D is showing the pseudotrigium secondary to a chemical burn. So what will be the clinical features and symptoms of the patient with trigium? Patients who present with a history of recent enlargement are more likely to require early excision for subsequent aggressive growth. Aggressive growth and in an atypical appearance should prompt excision biopsy. So patient usually comes to you when the lesion is becoming more aggressive and it is showing growth, an increase in the shape and size. Then a patient comes to you with the consultation. Most lesions, small lesions, are asymptomatic. Irritation and grittiness are caused by a Dalen. So what is a Dalen? So Dalen is some kind of, when the cornea there is some kind of a nodule or that is formed on the from the cornea at the limbus junction. So what happens is that adjacent to this the area, the tears do not adequately reach that part of the cornea. So what happened that due to the corneal dryness, the cornea get abraded, and so it leads to the localized marginal epithelial defect, and this is called the Dalen formation. So irritation and grittiness are caused by Dalen localized drying effect at the advancing edge due to the interference with the precorneal tear film, more likely if the head of the trigium is especially elevated. Patients who wear contact lenses may develop symptoms of irritation at an early stage due to edge lift. Lesion may interfere with vision by obscuring the visual axis or inducing astigmatism. There may be intermittent inflammation similar to pinguiculitis. Cosmesis may be a significant problem. Extensive lesion, particularly if recurrent, may be associated with subconjunctival fibrosis extending to the fornices, but that may cause restrictive ocular excursion. If pseudotrigium is suspected, there may be a history of a causative episode. So whenever you are suspecting the pseudotrigium, then you can also identify the what is causing the pseudotrigium. Like you can see the defect in the cornea. It can be central, it can be paracentral, and one of the most important thing is that the trigium induces astigmatism in the eye and causes the refractive error. So that is why we remove the trigium before any kind of uh, cataract surgery, because if the trigium is inducing astigmatism in the cornea, then if even if you remove the cataract, the patient will not be he cannot get the correction done fully. So we have to remove the trigium in this case as well. It is one of the indication of removing trigium. A trigium is made up of three parts: a cap, an avascular halo zone, halo-like zone at the advancing edge, a head, and a body. Linear epithelial iron deposition, stalker line, may be seen in the corneal epithelium anterior to the head of the trigium. Fuchs islets are a small discrete whitish flecks consisting of a cluster of the trigial epithelial cell, often present at the advancing edge. A pseudotrigium is classically distinguished by the fact that the location is away from the horizontal, though this may occasionally be seen as with the true trigium, and there is a firm attachment to the cornea only at its apex head. So what is this, the how many parts a trigium has? So this is you can see that this is a trigium and this is a cornea. So this is a body, very simple. So this is what you call the head, and head has a cap. So cap, and along the head there is a stalker's line, which is basically a kind of a iron deposition. It is a brownish line that is present, called known as stalker's line. And the Fuchs islets are basically the small whitish flecks that are often present at the case of the advancing trigium. So if that kinds of flecks are present, you know that the pseudo trigium is progressing and it is a progressive trigium. So how will you treat? Medical treatment of the symptomatic patient is as for the pinguicula. The patient should be advised to wear sunglasses to reduce ultraviolet exposure. Surgery, simple excision, pairs sclera technique is associated with a high rate of recurrence, around 80%, often with a more aggressive behavior than the original lesion. The trigium is excised from the cornea and conjunctiva, leaving bare sclera. Conjunctival autografting. The donor conjunctival patch is usually harvested from the superior or upper temporal paralimbal region. The graft is then sutured into the position using a 10-0 nylon suture. The site heals rapidly. Conjunctival graft can be secured with the tissue glue, for example, tissue fibril glue, rather than sutures, thus shortening operating time and reducing post-operative irritation. Adjunctive treatment with mitomycin C or beta radiation can be used in place of a patching techniques. Peripheral lamellar keratoplasty may be required for the deeper lesion. In a patient undergoing surgery for trigium, the risk of recurrence can be reduced by either using a conjunctival autograft or by applying the mitomycin C to the operating site. So one of the techniques to remove the trigia is just you simply excise the trigium and you leave the sclera pair. But what is disadvantage? Now this is not technique performed by ophthalmologist because of the high causes of the recurrence rate, and conjunctival autografting is very good procedure. That means that you remove the trigium and you so there will be the bare sclera. So whenever there is a bare sclera, you take the conjunctiva from the superior or from the temporal side onto the sclera and put it there and suture it with the nylon 10-0. And if you cannot use the nylon 10-0, you can also use the suture in that case. And you can also use mitomycin C or beta radiation if the trigium is having a recurrence and you are having excising a recurrent trigium. So it is very helpful to reduce the recurrence rate. And you can also do lamellar keratoplasty if there is a very deeper lesion and you can see that the cornea is very thinned out and after the excision. So this is the surgical treatment. 6.31 surgical treatment of pterygium, a removal of a pterygium head. B is showing the preparation of the conjunctival autograft, and C is showing the graft suture into the position. So next is the concretions. So concretions are also a smallish calcium containing deposits into the conjunctiva. Concretions are extremely common and are usually associated with aging, although they can also form in patients with chronic conjunctival inflammation such as trachoma. They appear as a multiple tiny cyst containing yellow-white deposit of the epithelial debris, including keratin, commonly located subepithelially in the inferior tarsal and fornical conjunctiva. They can become calcified and particularly large may erode the overlying epithelium and may cause marked irritation. If symptomatic treatment involves the removal of at the slit lamp and with a needle under the topical anesthesia. So basically, what is a concretion? So concretion are basically the yellowish white granules that are formed in the conjunctiva that is usually present inferiorly or in the fornis conjunctiva. And the question is, do we remove all type of concretions because it is so common and patient usually presented it? The answer is no. You do not. If the patient is asymptomatic, why to make a surgical procedure to the patient? We only operate when the epithelium is of the conjunctiva is eroded and it is causing the marked irritation in the patient. So how can you do it? You can put the fluorescent staining, and you can see that if the staining is positive, then the epithelium is eroded there, and then you remove the concretions. So conjunctivochalasis. So conjunctivochalasis is basically the redundant fold of conjunctiva that is present in the inferior side of the eyelid, superior side of the inferior eyelid basically. And why it happens is because of the loosening of the adhesion between the tenon capsule and the conjunctiva. Conjunctivochalasis, and what is the one of the important thing you must remember, what is the analogous of the conjunctivochalasis? Then it is a SLK, superior limbic keratitis, conjunctivitis, and basically it is occur in the thyroid eye disease, and in this case the superior side of the conjunctiva is affected. Conjunctivochalasis usually appear as a fold of the redundant conjunctiva interposed between the globe and the lower eyelid, protruding over the lid margin. It is probably a normal aging change that may be exacerbated by inflammation and mechanical stress related to dry eye and lid margin disease. Symptoms include watering of the eyes due to obstruction of the inferior punctum and the interference of the tear film meniscus. Treatment consists of a topical lubricants and treatment of any blepharitis. A short course of topical steroid or another anti-inflammatory agents may be helpful. Conjunctival resection can be performed in severe cases. So 6.32 is showing us a small concretion, B is showing the large concretion eroding the conjunctival surface, and you can see that this is a conjunctivochalasis, the redundant fold of the conjunctiva that is visible. So and then you can see the conjunctival cyst. So this is a conjunctival cyst, and C is showing the hemorrhagic lymphangiectasia. Retention primary epithelial inclusion cyst. Conjunctival retention cysts are a thin walled lesion on the bulbar conjunctiva containing clear or occasionally turbid fluid. They do not usually cause discomfort. They may be mild, causes blemish. Histologically shows a fluid-filled internal cavity lined by a double epithelial layer. So there will be the fluid-filled cavity that will be lined by the double epithelial layer. Treatment, if required, is initially by simple puncture with a needle under topical anesthesia, but recurrence is common. Bleeding should be encouraged within a ruptured cyst as it may promote adhesion of the wall and reduces the chance of recurrence. Cyst wall excision under topical anesthesia can be carried out for recurrent cyst formation. The differential diagnosis includes secondary inclusion cyst following conjunctival surgery and lymphangiectasia. The latter is characterized by the string of a cystic or sausage shaped clear walled channel which may become filled with fluid, hemorrhagic lymphangiectasia. So basically, how do you treat the conjunctival cyst is you puncture it with a small needle, and if the it is still recurrent, we do the cyst excision in this case. Subconjunctival hemorrhage is a very common phenomena that is often idiopathic and apparently spontaneous. Occurring particularly older individual, it may be result from surgery, conjunctivitis and trauma. The hemorrhage is usually asymptomatic, but momentarily sharp pain or snapping or popping sensation is sometimes felt. Coughing, sneezing or vomiting are a common precipitant. In younger people, contact lens wear is common association, and in older individuals, systemic vascular disease, hypertension is prevalent. A local cause should be ruled out by the slit lamp examination. Patients are often taking aspirin or similar products that can have an effect on the platelet function. Bleeding diastasis are a very rare association, but vitamin C deficiency and abusive trauma should always be considered in infants. The vision is usually unaffected unless of substantially elevated hemorrhagic lead to a large localized corneal wetting deficient talent, which is often uncomfortable. A large bleed can track into eyelids. Spontaneous resolution over a week or two is typical, but 2 or 3 narrowly spaced episodes are not uncommon. So basically, what is a subconj hemorrhage? Subconj hemorrhage is basically the hemorrhage that occurs in the subconjunctiva, and you can see that it is a very dark hemorrhage that occur in the conjunctiva, and it can be idiopathic, and there are certain precipitant in the cases of this. It is usually patient just notice, it can be asymptomatic, and patient notice that redness in his or her eyes. And some precipitants are like when you are doing a vomiting and you are doing the valsalva maneuver, or you are coughing or sneezing or straining. In these cases, it can also cause the rupture of the conjunctival things vessels. And sometimes whenever you are doing a surgery, you just puncture the conjunctival vessel. In this case, the subconjunctival hemorrhage is very common. So basically, the treatment is usually it will resolve on its own in 2 to 3 weeks, and the patient does not usually require any kind of treatment. So that's it for the conjunctiva. See you in the next lectures.